Welcome to another episode of Medicine 3.0. This week, I've got Dr. Michael McConnell. He's a cardiologist at Stanford and really has done amazing work over the years. He's a preventative cardiologist, so it's all about prevention. He wrote a book recently, Fight Heart Disease Like Cancer, which we go into how to think about heart disease, how to kind of think about it like cancer. I think if you frame it like that, if you told somebody you have cancer, they get really worried. And I think we need to treat heart disease the same way. And we dig in this conversation. I think you're really going to enjoy it. Very excited to have you. And I'm going to start with the same question I ask everyone. How did you get where you're at knowing what you know?
Okay, great question. Let's see. I was born in Brooklyn, but I got early on was super interested in sort of math, science, technology. Went to MIT. Then I sort of got the bug around studying the heart. That led me to medical school. That's obviously sort of a bunch of years. I was at Stanford for med school, came back to Boston for cardiology training. The main initial technology I was super interested in was imaging. So how do we use things like ultrasound and MRI to see inside your heart, detect early disease, all sort of non-invasively. I came back to Stanford as an assistant professor. I've been there ever since. And during that time, I think a lot of the interests that I developed around the imaging, as I said, was how do we see early disease? And that got me into prevention and running our preventive cardiology clinic. And around that time, mobile wearable devices were coming out. We did a big project with Apple using your phone as a way to collect data about your health. And that had me interested in how do I do prevention at sort of bigger scale. So I worked for about 6 years with different parts of Google, which included Fitbit. And then, most recently I stayed sort of part-time clinical at Stanford, but then still trying to do this prevention at scale. And we can talk about, one of the companies that I work with is actually trying to implement as a product something we had developed when I was at Google. So excited to talk about prevention and health tech. And thanks for the opportunity.
Yeah, I mean, obviously you covered kind of decades in that like short history lesson on your life we just took, and just amazing things from East Coast to West Coast, from non-medical to medical, to the biggest technology companies in the world, and trying to solve the number one killer. So all super fascinating. I want to take us back. How did you know that you wanted to be a doctor? You said you kind of got interested in the heart. At what point did you say, I really think I want to be a physician?
Yeah, it's interesting how that develops. I was very excited to be an engineer. I stayed on at MIT as a graduate student. Again, sort of applying technology to, it was basically a biomedical engineering degree at that point. But I honestly, what happened was when I really focused in purely on the engineering part, and I had sort of stepped away from a lot of the other more social activities I had done as an undergraduate, I realized I felt a little sort of half empty. And I realized that I love the technology, but I love working with people. I had a number of opportunities both before college and during college to do a lot of teaching. And I really loved explaining things to people and teaching. And so this sort of integration of helping people, but still be technology focused, as soon as I really made that change, I became a much happier and felt like sort of, gave me the ability to do sort of both parts of my brain. And so I've, been fortunate to be able to sort of follow that path, even though, as you can tell from the story, it's had a number of deviations along the way.
Yeah, I mean, but pretty cohesive in this love of, technology, engineering, and then clinical knowledge and really kind of ending in spending the last, it sounds like, a couple decades really working on preventative cardiology, which I think, I want to talk about your book. I want to talk about the newest company you're at. But before we get to that point, I'm curious if you're explaining to somebody about heart disease and how they should think about heart disease, how do you talk somebody through why they need to take it serious? What's the framework that you use for that?
Yeah, well, you might guess from the title of the book that I wrote, and the book really is designed for a general audience, and the title is "Fight Heart Disease Like Cancer." I think a lot of when I first got into studying heart disease, and the main form of heart disease that causes heart attacks and strokes are these small growths that happen inside our heart arteries. So even though we call it heart disease, it's actually mostly an artery disease, right? The arteries are what supply the blood and oxygen and energy to all of our organs. And our heart has a blood supply and our brain has a blood supply. Um, and yeah, early in my training, it was all sort of viewed as plumbing, and gradually they get clogged up and narrowed. But then a lot of very smart people who preceded me had figured out how to either, bypass surgery to go around what we call blockages, or to put stents in. Um, but then it became clear, and this is actually, if you go back a few hundred years, there were pathologists who were trying to tell us this all the time, that these growths happen very early. They're really active biologic processes, more similar to cancer in some ways, and that they're growing, they're destroying some nearby tissue. And so what I try to say in the book and sort of frame it is we have now the ability to detect these growths early on, and to, between lifestyle and medication, and that becomes an individual sort of personalized guidance. We have the ability to sort of stop this in its tracks and not wait till these blockages become advanced. And I think the other part where I have a phrase in the book that it's like heart disease, but like cancer, but in some ways worse, and that you can have one of these growths that doesn't cause symptoms. It's not very big, but a blood clot can form on it and block your artery, and and then your heart can stop. And one of the motivations for the book is that's what happened to my father-in-law. And he was fine one day and had given a lecture in a bus going back to the hotel after the lecture, and when they went to have him come off the bus, he didn't wake up. And so it's, how do you find that right balance? It can be a scary disease in that way. And on the other hand, we're in this amazing era of tools, both for prevention from a lifestyle perspective and from a medication perspective, that, we can really stop this. And, my view is we shouldn't be having people who have blockages and need stents or bypass surgery or having heart attacks. And, so now I view if somebody has a heart attack that I'm involved in taking care of, to me, it's like a plane crash, right? What did I do wrong? Where did I miss the signals? We should be, monitoring and picking things up earlier, and stopping it before we get close to that issue. So.
Yeah, I do feel like it is, thinking about fighting it like cancer is a different framework than most people have heard before. And I think that it's really important. You talked about your father-in-law, which I'm really sorry to hear that story. It's actually very similar to my story, where I'm doing this because my brother-in-law had a massive heart attack on a mountain bike and was one of my best friends. And I, I was so surprised and never would have thought he was the guy that was going to have a massive heart attack and die. And it just goes to show that it's, you know, arterial disease, heart disease is not one of those things that you can just see by looking at somebody usually until it's pretty far along. And so let's talk a little bit about like how early should somebody start screening? What does that screening look like? And like, how do you kind of think about that?
Sure. I'd say, for most, we can talk a little bit about kids because there is actually guidance around that. But starting with adults, the main tool that we start with is what we call doing a risk score. And that involves many things that probably people in the audience would guess, which is, how old you are, male or female, um, how bad your cholesterol is, your blood pressure, whether you have diabetes, whether you smoke. Um, so that originally came out of the Framingham research study. That risk score has been broadened to involve many different populations so that it is more broadly applicable. So that's the first step to basically say, are you at some increased risk? There are some key other sort of risk, what we call risk enhancing factors that don't go into the score, but you should think about. So a strong family history. So like I talk about my wife, not only did her dad have a heart attack, but her mom had a stroke when she was only in her 60s. And for a woman to have a stroke in 60s means that your kids are at increased risk. So it really starts with a risk assessment, using the score and sort of questionnaires. Uh, but then the main tool most of us use in prevention is what we call a coronary calcium scan. And so once someone's risk factors add up enough to say, and typically that could be when men are sort of around the age 50 and women are around the age 60, that a fair number will have enough of a risk score that it's likely that if you did a calcium scan, that you would pick up early disease. And one of the things that came out, after or sort of around the time that the book had come out, is one of my colleagues at Stanford had then published sort of using this calcium scan as basically a staging system, sort of borrowing the language from cancer, where, the more extensive the disease or the more it's spread, that's a higher stage. We talk about stage 2, stage 3, stage 4 of cancer. So they actually published on, based on the amount of calcium that's found, that would correspond to different stages of this underlying heart disease. And then just like with cancer, then you would sort of more intense therapy when you're at higher stage. So that's, we can talk about kids a little bit as well, but that's really the main steps. And there are some newer technologies that are out now. We may, if there's time to touch on, that actually didn't make it into the book. So, things move so fastly in this field. As soon as the book comes out, it feels like there, 5 more things that have been developed since then. But
Right. Yeah. Well, it was exciting last year to see the American College of Cardiology and Heart Association come out with their 30-year risk instead of just 10-year risk. I mean, risk horizon to me is also just so key. If we only think about, 10-year risk, are we looking far enough out to be as preventative as we can be? I mean, ideally, like we would know in our early 20s what our risk is and would be able to kind of adjust accordingly. But of course, some of the screening tests like a calcium scan, there are risks. I mean, there's radiation that you're getting and things like that. And so when you go through the risk scoring and then maybe somebody moves on to a calcium scan, do you think what other things can we do younger than that or earlier than that? Obviously, family history taking, things like that. What else can we do kind of even more proactively?
Sure. Well, I mean, one of the guidances that the Heart Association has had for some time is sort of their what originally started as sort of Life's Simple Seven. Now they call
Yep.
Life's Essential Eight. And that really highlights what are those, a lot of them daily things that we can do to keep us healthy. And one of the things that I tried to highlight as a positive in the book is we don't tend to think of cancer as preventable, but physical activity, maintaining a healthy weight, many of the positive lifestyle changes that the Heart Association recommends, they're also on the Cancer Society,
Yeah.
Website as valuable prevention activities. So, but yeah, those 8 things. It's always a good quiz to make sure I remember them all. But when I talk about the big 3 from the medical standpoint, are so your blood sugar and your blood cholesterol and your blood pressure.
Yep.
So those are sort of the more medical things. But then physical activity, a healthy diet, not smoking, maintaining a healthy weight. And then the 8th one that they added was, getting a good night's sleep, because of more and more data that impacts heart health as many other, as well as other health conditions. So
Yeah.
in the book, I highlight a couple of others that haven't quite made it into the AHA's list, which is, I think, unfortunately for many of us who like a glass of wine here and there, the adage that sort of 1 or 2 glasses of alcohol is heart protective. I think most of the data would say that that's not anymore the case, and it's always been associated with somewhat more cancer risk. So that would be sort of number 9 on the list. And then I think, as most people know in their daily living, that sort of stress and well-being has a big impact on our health, both mental health and physical health. And so trying to make sure that, you address that, so those are sort of what I call sort of the main 10 things. But it becomes a long list.
Yeah.
From a technology standpoint, they're one of the groups out of Mount Sinai in New York, has been looking at ultrasound of blood vessels as an earlier way to detect plaque buildup, because calcium forming in the heart arteries may come late. And then, certainly at some point we can talk about, imaging of the retina. The back of your eye is filled with blood vessels, both arteries and veins. And, it was a big scientific discovery a couple of 100 years ago that when they figured out the optics, that a human could look into the back of another human's eye and see all the detailed blood vessels there. Now we primarily do that with advanced cameras to make it, easy to do without needing to do the dilation drops and things like that. And then we use AI to analyze the vessels and all the other features of the retina, so that we can look, does your retina look like it's aging more rapidly than others your age? And also look at detecting cardiovascular risk and kidney disease risk, among other things.
Yeah, let's talk a little bit about retinal imaging. I think it's interesting. So for people, retina is obviously the back of their eye that is not visible to the naked eye. And it is fascinating as a clinician being able, like, you can't see people's blood vessels anywhere else in the body with that kind of fidelity, other than getting a good look in the back of somebody's eye. And having done, tens of thousands of eye exams, it's hard to actually do a really good eye exam with just, an ophthalmoscope, just the thing that the doctor's holding and trying to look in the back of your eye. So Yeah, kind of explain to the audience, what's the retinal scan kind of like? Some of them probably had it before, and then how do we use that to actually predict disease? Like, how predictive is it? How useful is it? What can we use it to put people on medications?
Sure. Yeah. So, sort of for many people, if you've been to an eye doctor, either optometrist or ophthalmologist, they may include doing an image of the back of your eye, where most of the time it's a camera that's just sitting, on a table that you put your chin down, and then it takes a picture from one eye to the other. There's a flash involved. Um, and if you've ever gotten a chance to see them, you see this incredible branching pattern of your blood vessels as they supply the back of the eye. Um, and yeah, when I first got involved in this was when I was at Google, and they had developed an AI tool to detect sort of a form of more advanced eye disease that diabetics are at risk for. And they basically trained it, not to oversimplify, but the same way that they trained, how does Google know when you upload your photos of cats versus dogs, or
Hmm.
now you can put in somebody's name and it'll find all the photos of
Right.
them. That uh, this whole area of what's called machine learning, where instead of me trying to tell the computer how to figure it out, I just say, here are thousands of pictures of cats and here are thousands of pictures of dogs. And then, it basically trains and learns. And that's what Google did for this eye disease, which was it gave, you know, tens of thousands of images of those who had what we call retinopathy, or sort of disease of the retina that diabetics get, versus healthy eyes. And then, so the machine trains on these thousands of images. And then when you give it a new image, it says, okay, that one looks like, the retinopathy versus healthy. Um, and the team at Google then thought, well, could we do that for all those different risk factors that I talk about? Can your retina predict your age and your sex and your blood pressure and your glucose? And it turned out that it could do those things pretty well. And that's when they called me up and said, look, we seem to have all the pieces of a heart disease risk score from the retina. And so, yeah, that first publication, we showed that uh, the retinal AI, so the computer could generate a risk score that basically matched, the accuracy of the risk score that, the standard risk score, sort of that Framingham kind of risk score.
Hmm.
Uh, and that's why, now I've been working with a small company called Toku that's trying to turn that into a product. So we've, shown our technology to the FDA. The FDA says, okay, that looks good. Now, do the clinical trial in the US, where you start, because what I described, you're using sort of existing data to develop the AI tool.
Hmm.
But what the FDA wants to see is, does that work well going forward and in a diverse population? So that's what we're in the middle of doing now, so that we can show that, it's accurate enough against the standard risk score that the FDA would give it the thumbs up. So.
Yeah. So in the not distant future, it won't be just when you see your doctor that you talk about heart risk. It might be when you go get your eyes checked.
Yeah, and to us, this we think is just an amazing opportunity. The numbers we've seen, there are over 100 million eye exams
Hmm.
done in the United States, which is actually more than physical exams that
Yeah.
a primary care doc may do. And so we think it's an opportunity, right? Not everybody's day to day, unlike me. Most people are not thinking about their heart disease risk every day.
Yeah.
And so, um, why not, when you're making contact with optometry, ophthalmology, getting an eye exam, that there's an opportunity to say, look, your retina looks like you have some increased risk. Let's really get that full evaluation and make sure, because unfortunately, while we have all these good preventive therapies, only about 1 in 3 eligible people in the U.S. Are on, a cholesterol-lowering medication, even though the guidelines would say they should be.
Hmm.
So there's really an untapped large number of, not only in the United States, but around the world, of people who have increased risk, the science would say would benefit from preventive therapy. They're just not aware of it.
Yeah.
And, as you know, when you see your primary care physician, often it's for whatever immediate issues are going on. And it can be hard to set aside time to do more extensive prevention. So we're really trying to up level everybody thinking and using that opportunity of an eye exam to say, let's think about your heart health and potentially at increased risk, and what can we do early to help prevent heart attacks and strokes. So
Yeah. And it sounds great to have a passive way to, like you said, more eye exams. And people like to see, they like to, they need their glasses prescription, their contacts prescription. And so I think that's an amazing opportunity to take advantage of. And much like you, I'm very passionate about, like, how do we get people on the right therapies to prevent disease as much as possible. And what I think is interesting is at least I run into a lot of patients who they're not interested in starting on a medication. I hear again and again, like, I don't want to start a medicine. How about you try some supplement on me instead? And so I'm curious, how will you talk to patients when you're talking about, their risk is at a certain level, they should really think about some sort of prevention? How do you discuss that with them?
yeah, awesome question. I'd say it's one area where imaging helps, right? When you do a risk score, it's a bunch of numbers. It goes into a calculation and it pops out with a number. Um, Whereas if you say that, we've looked at your blood vessels and there's evidence that, everybody's different, and sort of that comment you made earlier, you can't just sort of look at somebody and say, you're perfectly healthy, whereas you have heart disease. You can make rough guesses, but
Yep.
we shouldn't be guessing, right?
Right.
So, that is one of the things that I think is very helpful in communicating with patients, is that if we see changes, either through the AI or, as the example of the calcium scan, we see disease in your arteries. And so, and that becomes a great opportunity to sort of make that shared decision around, the potential for adding medication.
Mm-hmm.
And there are actually publications showing that when you include imaging results, that it is more motivating for people. And yeah, that circles back to the example around cancer, right? I think people have very visceral response to saying that, we detected a cancer growing in,
Right.
even though there are some cancers, say like prostate cancer, that can be slow growing and indolent. And, but I think people think of heart disease still as sort of a plumbing or clogging, and not as a growth that if you don't address when you see it, could cause a heart attack, sort of out of the blue, without the ability to have prevented the consequences from that. So,
Yeah. And I think it's interesting when I think about the risk factors. You named the 3 medical risk factors, right? So you've got your LDL, your cholesterol, you've got your glucose, and you've got your blood pressure. And, you know, I hear a lot of patients who say, well, I just want to try lifestyle to start. And I just have to say, in my experience, lifestyle doesn't usually work. And I would much rather start a medication and change your lifestyle, and then test, could we go off the medication in the future? Like, let's start trying to lower your risk as quickly as possible. Um,
Yeah, I'd
and
have to say
yeah,
I have that kind of conversation with many patients,
hmm,
but yeah, and you, I think everyone's different. You work with the patient in front of you, and
right,
you try to give them the best evidence and science. Occasionally, I've had patients who, you know, all of a sudden they come in and their cholesterol had doubled, and then you ask them, and they had gone on a paleo diet, and all of a
right,
sudden, went from sort of a plant-based diet to a meat-based diet, and
right.
had a big jump. And so there are, I think I had another example of a patient who, um, you know, back in the early days of pedometers, uh, when he found out that he sort of two things happened around the same time. His primary doc was telling him he needs to go on insulin. At the
Hmm.
same time, he found out that, his granddaughter needed more help in her upbringing. And those, two events got him just all in on, getting 10,000 steps and changing his diet. And, so he had big improvements in his diabetes and blood pressure. Uh, I I did put we never took him off the cholesterol medicine because we knew that part of the risk. But yeah, I'd say, we certainly encourage, and some people have strong response and others less so. But it's often that combination, right? The more you can do with lifestyle, the less you need medication.
Yeah.
So that's sort of part of the bargaining or discussion that we have.
Yeah, absolutely. I think you named the great eight, the eight essential eight things to work on to live a healthier life. And it's what's interesting is it's just like you said, it's not like those eight things are isolated to heart disease. We know that those things help with cancer, with dementia, with metabolic health, bone health, like everything. And so those basic things helping people to do those changes, it's really hard as a physician. You usually don't have time to really coach somebody. They need to work with somebody else to be able to do that. I'm curious, when we've talked about, okay, you've got blood tests and we'll do some scoring based on risk factors to know what kind of imaging to do. We have imaging, whether that's ultrasound or a calcium score. And then, there is kind of this more recent change of these uh, arteriograms or these CT angiograms where we can see the soft plaques. And there are companies like HeartFlow and Clearly that are trying to push us in a direction towards using those. And I'm curious, in your practice, where do those kind of fit in, to, is it only people with positive calcium scans that you think should get those tests? Is it people with a high risk with maybe a negative calcium scan and you want to see if they have soft plaques? How do you kind of think about that?
Yeah, I think you hit on a couple of great use cases there. Um, yeah, and that was, as I was saying, one of the things that didn't make it in the book, um, was sort of what is the role of what we call, right, a CT angiogram. So a calcium scan is a very rapid CAT scan, uh, but there's no dye. You don't need the IV or anything like that. So the CT angiogram, they give the dye through the vein and they time it so when they inject, then it's flowing through the heart just as they take the picture. So you get these beautiful three-dimensional images. And I'd say in many people, they have, as sort of the traditional time we do an angiogram where someone's having chest pain, we're trying to figure out if it's related to a severe stenosis or blockage, that doing this CT angiogram, that technology has advanced where it's now quite accurate. Um, the the real question then becomes, we know the calcium scan is, for most people, is a good way to detect that the disease is now present and that the process has started. But one of its big disadvantages is that calcium is more sort of an aging phenomenon that happens within the plaque. So plaques usually start off with a lot of fat in them. They're soft, as you were saying, and then over time they can calcify. And so the calcium scan just picks up the calcified part. And so it doesn't see all of the plaque. And then even when you're on good preventive therapy like statins that get the cholesterol down, because it's sort of more of an aging process, the calcification continues, even though lots of other studies have shown that the soft part of the plaque actually shrinks. So one of the big challenges is, okay, and there's a section of the book that talks about this, that typically in cancer you have a good way to say, okay, you got your chemotherapy and now go back and look and see, did that take care of your cancer? The calcium scan by itself doesn't do that very well. Your calcium score continues to go up just because those plaques are aging and calcifying.
Yep.
And so that's where a lot of interest in using these CT angiograms and AI tools to then quantify how much plaque is there total, how much of the sort of soft, non-calcified plaque. And then sort of the key question is, does using that information and following it over time sort of tell you, are you on the right therapy? Have we gotten your cholesterol low enough? Is it really making the plaques shrink or not? So that's been a big sort of what we like to call, like in the Stanford biodesign program, an unmet clinical need, right? We have early detection. We don't have a great monitoring tool. And so that's where Stanford and a number of other institutions are doing clinical trials to say, does including that CT angiogram in guiding the intensity of therapy, do people do better when you do that? You had the question of sort of how do I use it currently? A few different ways. In those who've had a positive calcium scan, there are some where the calcium is present in one of the arteries that's sort of a higher risk, what we call the left main artery. And based on some other research, seeing calcium there means there's a chance that there's a bigger plaque in that vessel, and that vessel is so critical that even if you don't have symptoms, we would likely treat or intervene on. So that's one use case. In a few patients, I have started to look at getting a baseline to be able to follow over time. And then I think your third example is, when patients have often a strong family history or other very strong risk factors, because calcification, again, comes more with aging of plaque, you can have a lot of soft plaque and still have a 0 calcium score. In general, that's pretty rare, but in people who you think have really accelerated heart disease, strong family history, or they have very what we call familial hypercholesterolemia. They have a gene that gives them very high cholesterol. In those settings, relying on a negative coronary calcium scan is probably not sufficient. We tend to treat those patients more aggressively anyway, but if there's questions about how much plaque may be formed before it's yet calcified, so in some cases using it then. But I'd say, we're still learning these AI tools to quantify the coronary plaque are relatively recent, and as mentioned, there are clinical trials going on to help guide, what's the best way to use these going forward.
Yeah. No, definitely trials that we'll keep an eye on and help guide us as we try to give the best care to our patients. Mike, amazing conversation. Thank you so much for sharing your knowledge with all of us. Where can people, if they want to follow your work, if they want to find out more, where can they find you?
Sure. Well, if you Google "fight heart disease like cancer," that's has how you'd find the book. I also have a website that's just those letters, fhdlc.info. So there's a little bit more info there on how to find the book. And in the book, I link quite a number of other websites and videos to help teach more about heart disease. And I think I have a few examples of podcasts and links to those on that website as well. But yeah, no, a super pleasure to talk about this. Obviously, I get very excited about prevention. I think we're in this amazing era of being able to do early detection and really treat and reverse the disease. So encourage everybody to make sure, not only for themselves, but family members, make sure you know your risk and yeah, get earlier is better. So.
Yeah, it's one of those interesting things. You may not know how many lives you save just by people listening to you. It's different than, somebody has a heart attack, goes to the cath lab, you open them up, you save their life. Like right now, if we can get people to listen to the words that you're saying and to take it serious and do the screening necessary and do the treatment, it's going to save lives. So thank you so much for the work you do, Mike. And thank you for joining us today.
Oh, thanks, Jared. Yeah, it was a pleasure.
Thank you for listening to another episode of Medicine 3.0. We make this podcast so that you know where to turn for good information on keeping you and your loved ones healthy. Feel free to check us out at bionichealth.com, where we can help you live a longer, happier life.